without further ado, I will turn it over to Dr. Grace. We're very happy to have you here join us today, and we look forward to your talk.
Thank you so much for having me. And I'm just just congratulate all of you for the excellence of your network and how much you work together. And I've just watched the work that you've done with just a lot of enthusiasm. So thank you, and shared it myself and whatnot. So I wanted to talk about physician factors affecting use. And there's probably many physicians on the call as well. I thought I'd start by just reminding us why it's important, but I know that we're all quite aware of it. So I'll do that fairly quickly. But you do have some really great data from Michigan on this importance that I wanted to just highlight. And then we'll get into like barriers, attitudes. So why physicians aren't referring to optimal levels, and then thinking about how we can overcome this. I don't think, unfortunately, there have been any studies on, how we can change attitudes of physicians, but we can certainly kind of build systems to support them. So cardiac rehab utilization, just to make sure, again, we're on the same page. You were just talking about kind of getting enrollment or participation up to 30%. And so, enrollment, adherence, completion, these are all behaviors on, the part of patients that we want them to engage in. But referral is, this is a physician action required. Patients often don't even know rehab exists unless they're referred and told about it. So they're really important gatekeepers in this process. When we're talking about referral to rehab, the specialist is really key. If we refer as inpatients, we get patients in sooner to rehab, so lower wait times, which is equated with much better outcomes. But, the communication with the rehab program and with the patient is also very important. And, getting that patient involved in the discussion can really support their enrollment, making sure we have their consent, that we're identifying any barriers from the outset and thinking about, which program we might refer them to, where there is choice. So, some representative data from the US, it's a bit dated now, but suggesting, about 60 to 65% of patients are referred. So we certainly want to be working on getting that higher. And if we look at, think about this in relation to other guideline recommendations for cardiac inpatients, you can see that the other ones are implemented to such a higher degree than rehab referral. So we are the outlier, and we need to do something about this. Here is data from the Pinnacle registry from the US, so US outpatients, and we see a similar situation. So while there is a bit more variability in implementation of the set of recommendations for cardiac outpatients, nevertheless, the lowest is cardiac rehab referral at only 12%. And so rehab referral rates aren't just low, but they're also inequitable. And here's some great recent data from your state showing inter-hospital variation. So some of them are performing quite well, and other ones definitely not. Inequity also comes in terms of social determinants of health. So here, for example, data on women, but this could also be, ethnocultural minorities, for example. But across many studies, you can see this review shows that many more men are referred than women, and this is a statistically significant difference. Now, the reasons for this are quite well known, and they're multi-level. So there are factors at the health system level, there are factors at the patient level, but we're here today focusing on provider level factors. But I just wanted to remind everyone that we can't just intervene at this level alone because there are other factors at play as well. Another reason why it's so important that we focus on physician referral is the strength of their endorsement is such a strong predictor of the patients who ultimately enroll. So, Phil Adie's had his seminal work where he showed the importance of physician endorsement. And we've gone on to kind of measure it on a 5-point Likert scale, 1, not very strongly endorsed to go to rehab, and 5, patients perceive a really high endorsement. And while arguably a physician might have strongly endorsed and rehab, and the patient didn't capture that because maybe they were sedated or they were anxious or there was a language barrier. Ultimately, whether the patient perceives they were strongly encouraged to go, results in whether they go to rehab or not. So you can see here that the patients that went perceived a significantly higher endorsement than those who didn't, and this was actually 2 times greater participation with this endorsement. If you look at the patient level too, and when we ask them about why they don't go, there are certainly many barriers and many legitimate barriers to going. But, one of the main ones is this function of being referred, right? So they have to be referred. They have to know about rehab to go. I really like this data too from your state. So here's there was an excerpt from a very long table, and so I'm just cherry picking here for the point to make my points. But so here's data on the characteristics of hospitals that had more 90-day cardiac rehab use. And one of the significant factors was that patients perceived the doctors communicated well. And I bet you this means that the doctors were communicating also about rehab referral, and that was resulting in greater rehab use. So, we started studying, reasons why this was happening. So why are physicians not referring and encouraging to the degree and universally? And so we started with some qualitative work, we moved to some quantitative work and some reviews. So I'll summarize that with you. So here are some, I thought, quite compelling and telling quotes directly about, why this might not be happening. So one person spoke about, cardiologists not being convinced of the benefits of rehab. A clinician scientist who would know the evidence on the benefits of rehab confessed they rarely referred. Another person talking about, if a surgeon tells a patient they need to go to rehab, it means the surgery wasn't successful. So kind of this curative approach, not thinking about the chronic nature of atherosclerosis and vascular diseases. And then there's kind of the issue around territoriality that we're going to see in some of the reviews too. So some doctors don't refer because they're afraid our doctors are going to steal their patients away, or maybe they're worried about, changes in medication or other recommendations that might conflict with their recommendations. And then just finally, is kind of a comment around the luck of the draw and who might be the attending physician when you happen to have your MI, as a patient, and who's working on the ward. So if there was an attending physician who automatically referred, well, you were in luck. But other physicians had their biases, their opinions, and they just wouldn't refer. So it's kind of random in terms of which attending physician you had. So we went along and developed a psychometrically validated scale, the PACR, so Provider Attitudes Towards Cardiac Rehab and Referral Scale. We actually have a revised version now, and I'll share the link to that at the end. And again, the slides are coming to you. So while there are many links in the slides, you can certainly have a look at them at your leisure. But here are the most kind of strongly endorsed factors that dissuaded referral. So not being familiar with sites outside an area, so where patients live farther away, lack of a standard referral form, perceiving patients won't follow through. So that could be legitimate if there was a discussion and the patient, stated that, but sometimes it could be an assumption and it could be an erroneous assumption. Reimbursement policies for referral. And then the final issue is around kind of responsibility. So there are many physicians involved in the circle of care of a patient, and there is no guideline about which provider, whose responsibility is it. And so sometimes maybe the specialist thinks the primary care provider should do it because they know the patient for a long time. Maybe the general practitioner thinks the specialist did it because it's standard automatic referral on the unit, and then a patient falls through the cracks. So there have been some reviews of the literature, so of the quantitative and qualitative studies by our group and a group in Australia as well. And it kind of reiterates some of these and adds some new points. So again, beliefs about the benefits of rehab, awareness of the benefits of rehab, the sites themselves and what the referral processes are, referral norms. So we do find that, say a physician is on an inpatient unit and other, providers are referring, then they tend to do the same. Or say, when you're doing your training, your residency, if, you observe, your superiors referring, then you might be more likely to do the same. Sometimes providers report safety concerns, and we talked about this a lot at our institution when we instituted automatic referral. So the physicians would say, I don't feel comfortable referring now because this patient wouldn't be safe to do an exercise stress test and where they're at right now. And so, we had to really talk to them about the fact that, a physician assesses a patient for a stress test, at the time, a little bit later on, and that one is present during the stress test. So they're not actually the responsible physician any longer. And so they can allay those concerns. This perceived patient motivation again, patient, saying, so say you're talking to a patient and you say, I'd like to refer you to rehab, and they say, I can't pay for it, or I live too far, I'm not going to go. You can see why a provider wouldn't want to put in the paperwork, and obviously you need a patient's consent to do it. And then finally, the idea of around a clinician's personal lifestyle and health beliefs. So I've seen good data showing that physicians who use tobacco are less likely to counsel about tobacco cessation. And I haven't seen the exact data in the cardiac rehab area, but I can imagine that clinicians who don't exercise or maybe who don't follow a healthy diet, et cetera, might be less eager to promote behavioral medicine and cardiac rehab referral. So as I mentioned, there's this validated scale, the PACR that we have, but there is another validated scale called the ReCare, developed by this group in Australia. So if you are interested in measuring the perceptions of the providers in your area, there's two places you can go, and they both have 4 subscales. They're both a little bit different, but there's some commonalities as well. But what's been interesting in the work coming out of this is that we've seen some differences in attitudes and barriers by the type of physician. So we've often seen that cardiac specialists have more positive attitudes about rehab than primary care clinicians. And it could be related to, again, this issue that there's norms on their wards. And often, right, when you engage or enact a certain behavior, then your attitudes do kind of come in line to support those behaviors, and so-called cognitive dissonance. And then we also saw some kind of difference with outpatient cardiologists and how the positive perceptions in that sample was really key. So things like, a patient comes and they say they had a bad experience in rehab. They perceive the program as poor quality because, they changed medications and it wasn't communicated to them. They aren't getting care summaries, things like that. So the next question then is, what do we do about it? So just in the last couple of minutes before we get to questions. So I haven't seen, as I mentioned, any data on how to change attitudes. With education, maybe that could be possible, and I don't want to rule that out. So we certainly do a lot of education of our inpatient partners, and some kind of audit and feedback about referral rates, and that has really had some impact. And Cochrane reviews do suggest that can have a small effect. But they do have some legitimate barriers. So I think it's helpful to build a structure around the referral process so that it is automatic and it just supports and kind of circumvents some of these issues around like time barriers and, what paperwork is needed, et cetera, who's doing it, that kind of thing. So you really want, especially now with electronic health records being so ubiquitous, if a patient has an indication for cardiac rehab, that it's really flagged and the key information to seamlessly flows to the cardiac rehab site. And we have it set up at our center that we're the one who knows all the other locations around us. So we actually triage to sites closer to home so that the inpatient side doesn't have to worry about that at all. There has been a randomized trial now of automatic referral. The effect sizes were not as exciting as I would have liked, because we identified all positive caths in the province, but we intervened with family physicians instead of specialists. So we mailed out to them. We didn't automatically refer, and then we actually had a lay phone call to patients who didn't enroll. And what you can see is it is significant in a randomized trial. But reviews show, it is impactful. Non-randomized studies shown here, though. I apologize, the font is very small. But these diamonds are kind of overall effect size or summary effect sizes. So you can see with usual practice, we hit about 25% referral. This is 0, this is 50, this is 100%, 25%. We have this systematic automatic referral, we can get up to 50%. As we're going to talk about in a second, discussing also with patients at the bedside, gets us there too. And putting those two together, wow, you're getting over 50%. These are a couple of studies on just letters, motivational theory-based letters. And as clearly we need some more work there, because that is very cheap and easy to do. But yeah, indeed, we did a Cochrane review, and we were able to pool data for the first time, showing that our interventions to increase patient use work in trials. They're so heterogeneous, though. There's quite a few different ones. But interestingly, our subgroup analysis really reinforced this point of the importance of physicians in this process. So where the interventions targeted the healthcare provider, not the patient, the healthcare provider, and where it was delivered face-to-face, there was much greater enrollment. So it's basically saying we need to train the providers to talk to patients face-to-face, and then the patients will enroll, right? And so I don't have time to show you this, but just to say that we've also observed patient-providers interactions at the bedside and coded them. And indeed, where physicians were more interactive, we did see in adjusted models, much more patient enrollment in cardiac rehab. So again, that discussion being really important, but also provider volumes, again, just that it is an issue that there are barriers around time for providers. But because of this evidence, we looked around, and there are no resources that we could find to train providers on, the importance of this encouragement and what the heck to say, right? So we kind of came up with 7 key points. These do need to be studied, but there's this free online brief CME accredited course. And, I encourage you to share it with your inpatient cardiac staff, nurses, allied health, and physicians alike. So just final thoughts, there's the reasons for underuse are multifactorial, but physicians are gatekeepers. Their encouragement is impactful, but they have valid barriers to referral. So let's work to set up systems to support referral. Automatic referral, a standard inpatient letter that goes automatically to patients, and then training allied health providers and nurses to support the bedside encouragement. And we have so many implementation tools, acknowledged partners, but lots of implementation tools that I encourage you to just steal and adapt for your own programs.